Well, John, here we are. I feel like we're coming to the conclusion of the book. We've got probably a few more episodes to finish this out. We're in the midst of the prosthetic, and let's talk about what factors are going to influence bone loss when it comes to multiple implants and splinting them together. We're talking about fixed partial dentures. We're talking about the AKA bridge. We're talking about if you're one of those guys that likes to splint your implants, well, you need to listen up. Right here it is. What factors are going to affect the bone loss around your implants or the bone remodeling, maybe the bone growth, if we're going to start splinting our restorations together? So, John, you and I think we've kind of learned some stuff from this chapter, right?
Yeah.
And there's some stuff that I was doing. I didn't even know why I was doing it. And I'm reading this and I'm thinking, oh, okay, right?
Yep.
That makes sense. It makes sense. So, John, talk a little bit about why someone, for the most part, would want to hook multiple implants together.
Yeah, we know that when we're doing fixed partial dentures, implant bridges, we've got to deal with how do we handle the connection from the abutment to the implant?
Mm-hmm.
How important is passivity of fit? And then how do we best connect multiple units to ensure a passive fit, number one? Number two, what type of abutment are we using?
Mm-hmm.
Are we engaging the hex, the taper, both? How important is the impression design? So let's kind of dive into this a little bit. One of the things he sets the stage with is the thought being at the beginning to maintain bone, that we want to try to have a passive fitting restoration. And this is maybe not the primary, most important factor with bone loss, but we certainly want to have a biomechanically stable connection that is not moving around.
Well, John,
And
the
we
best way to
know
have a
that
passive fit restoration is just mill 2 custom abutments and cement it in. You got the slop gap, right?
Well, so he talks about that, and he says that's kind of been the thought process, is that the cement can eliminate they can make it more passive.
Like the whole advent of the custom abutment, that the Atlantis concept that was developed years ago. We can now mill titanium and not cast gold restorations any longer. We can save you money and time and make all your implants parallel and then cement on your restoration just like you do any crown and bridge restoration. Yep. Well,
and I think that's the idea of the cement acting as a shock absorber, right, or filling the gap, and as he says later in the chapter, he says these claims are accurate when cemented restorations are compared with cast screw-retained crowns. Cemented are certainly more passive. However, recent changes in fabrication of screw-retained restorations have changed the situation. The introduction of milling rather than casting has dramatically reduced screw loosening. And also, we know now that we're cementing abutments, or we're cementing crowns over our screw-retained tie bases.
that's right.
That is giving us another. It's essentially meaning that both of them have that advantage. So we kind of look at cement, and it used to be the solution to this, but we're realizing now how important eliminating cement could be. So if our goal is to try to eliminate cement, we have to try to achieve a passive fit as best we can using good impression techniques. And so we could get into the high weeds on this, but we'll start here. He begins the chapter talking about how he takes cement, or how he takes impressions for a screw retained bridge. And he talks about how he will try to determine whether an engaging impression coping or non-engaging is the way to go. So in other words, does he use an impression part that engages the hex, or does he use an impression part that does not? And he uses a simple test of connecting them together with some autopolymerizing resin, and then seeing if he can lift it off with his finger with no friction, essentially, or no resistance. And if he feels resistance with the hex, then he's going to move to a non-engaging type of impression coping. So in the impression step, he's trying to eliminate as much of that misfit that he could have happen from a poor
And if you're
impression
following along
outcome.
in the book right now, there's an excellent demonstration, or actually a figure, where he shows what he's doing on page 186 and how he lutes those two together. Listen, this takes seconds, right?
Yeah,
And let me
very
tell you
quick.
something else right now, okay? Because let me tell you something else right now, John.
Yeah,
Okay, I
whoa.
don't know. I got serious right here.
Yeah, that was real.
This is where you're going to push the limits of your implant company's parts. Right here.
Yep.
Right? Because not everybody has this stuff, right? Not everybody has non-engaging abutments. That means you're going to have to learn how to cut hexes off. Not everybody has non-engaging even impression copings, right? Open tray, and even a good open tray impression coping, to much less just an open tray, right? So this is where you're going to push your company's like implant inventory parts list, right? And let me tell you what, don't just go thinking that you can go buy some off OEM part, like some third party, and make this kind of thing work. Because the inaccuracies start right here, right? It doesn't start with the model pour. It doesn't even start with the impression. The inaccuracies, John, they start right here with you trying these in the mouth.
Absolutely. And I think if we can eliminate or reduce, we shouldn't say eliminate, but if we can reduce inaccuracies from the impression using the right type of coping, whether it be engaging or non-engaging. Now, there is an advantage, as he talks about, if you're using longer span FPDs with, say, multiple abutments, of having at least one of those be engaging of the hex, because it helps you when you're delivering the restoration to have something that indexes the position.
Something actually I picked up right on this is like, you got 5 or 6 units that you're engaging, you know? Put
if you
one
just
of,
engage one.
Just engage one.
Yeah,
right?
If you can engage one, it's going to give you an easier time at delivery to be able to lock that into place. But right after he talks about that, he immediately goes into a segment on tie bases, on the actual abutment that we're using to connect to the implant and to the bridge. And he kind of debunks the idea that we have to have a hex. And this is something that kind of challenged my thinking, because I have always thought, well, I'm okay without a hex, but I'd like to have a hex. And why, I think, was because I remember being told somewhere, and this is one of those things you kind of don't even know why you do it, but that you would have less stress on the screw if you had a hex, because it would be anti-rotation. But he kind of debunks that, saying, hey, guys, we used non-engaging UCLA castable abutments for years and years before we had.
And that was on X-Hex too, I bet.
Right. It could be X-Hex, it could be old internal hex, and we never had issues. So what really matters here is the accuracy of the impression, the model, all of those things. And your anti-rotation should be based on the design of a fixed partial denture. The screw really shouldn't be doing any work that would compromise your and then I started thinking about that, and I thought, Wes, I've got all kinds of these non-engaging old, like say in my region it's Zimmer internal hex. I got a ton of old Zimmer, Calcitech, whatever you want to call the company over the years, with non-engaging
Dude, that doesn't
UCLAs.
even have like a internal taper of much of any way, no conical seal or anything, and yet you're not having prosthetic complications.
Screw loosening.
And the reason why is because you had an accurate impression.
Right, you had accurate impressions.
You had good parts. You had good stuff.
That starts to get us thinking that the hex, if you're relying on your hex to try to not have screw loosening, if you've had problems on, let me say it this way, if you've had problems with screws coming loose on your screw retained bridges that are non-engaging, it's probably that you didn't have passive fit.
Hey, some of you are using cheap impression material and cheap parts.
Ooh.
I'm just going to say it. And I'm going and I'm just going to say it, you're going to see complication. Right? If you want to use the generic brand stuff, use it for your crowns, right? But don't use it for this stuff.
This is where it matters the most.
Yeah.
And I think that's where, if we can accept, and he goes into great lengths to talk about that it's not important to have the hex in these restorations.
Let me say this one more time.
Yeah.
This book has some of the best images that you possibly can imagine. Like the photography and the examples are next level. Like hats off to the job that they did putting this together, because it is impressive. It's impressive.
Yeah. Well, so if you can get to the point of being comfortable with using non-engaging for your fixed partial dentures, then it opens up a whole new world, right? Because you start to go, okay, and he uses the example of Straumann. He says, okay, if I'm using Straumann and I'm okay with non-engaging, that means I've got 15 degrees of freedom in the Straumann bone level, which means up to 30 degrees of implant angulation difference is possible with a direct connection to the implant without any type of transmucosal abutment.
I think it's a real important concept to understand here. And some of you have been asking us for, what our recommended implants are for particular situations. And you look at the advantage of a Straumann implant in this particular situation is that it has, if you're looking at this on YouTube, if it has a 15-degree angle, right, coming up out of the internal conical connection, and you have another implant setting beside that that's off angle, it's like your crown prep upside down, right? That's how to think about it. If you prepped a crown or two crowns, two teeth for a bridge, and you prepped it at a 15-degree angle, well, will that draw, right?
Right.
It'll draw. That's a big, wide, internal connection at 15 degrees, and you put two of those together, man, you have 30 degrees of freedom.
Yeah.
To get passive.
So if you get down to kind of what people, like you say, Wes, have been asking us about is, well, okay, so what does this mean for brass tacks? This means that now you need to look at what implant system you're using, and you need to look at what is the connection and what are the degrees of freedom that you have to work with. And if you have a Straumann, or you have, let's say, a Zimmer internal hex or BioHorizons, something that has relatively wide angle that you're working with, you can probably do some splinting direct to implant with non-engaging. But if you have the type of implant that he talked about kind of preferring for subcrestal bone level type of implants with a Morse taper connection, which is a 3 to 5 degree connection, now we start to get a lot more limited in splinting. And this is what Wes and I have talked about a lot in the last year together off air, is if you have the same implant system that gives you probably the most stable, according to this book, the most stable bone at a subcrestally placed position in a thin tissue situation where you're driving the implant deeper.
Yeah, an immediate.
Now, if you want to do a bridge, you're gonna start having to be, you're more limited because you can't. I mean, you only got 6 degrees to play with.
Right, because here's what happens: is that he goes into this next, and he says there's tension. Right, there's tension. And so I experienced this on a recent case that I took off because this patient lost an adjacent tooth, and we were just going to extend a cantilever to the mesial off of a 3-unit or a 2-unit fixed partial denture, 2 implants splinted together, cantilever to the mesial 1 tooth. And when I took the composite out of the occlusal surfaces, and I went down in there, I said, one of these screws is not super tight. Like I was able to just back it off. But then I pulled the abutment off, or the abutment and crown, and I looked at the abutment, and guess what I saw on the abutment? Micro etching. So what's that? That's micro movement, right? So guess where I went wrong, right? Is I did not splint the impression copings together, right? That's number one. And number two, whenever I did splint them, when I didn't splint them, I wasn't able to check for passive fit or a tension-free environment. So it's on me. So when I'm redoing this, thank the goodness, right, that we did redo it for this patient because she needed another tooth, we did some extra stuff because of this book. Yeah, I changed the way I did that case. And now I have a true passive connection. In this particular implant design, it had an internal connection of 11 degrees. So that means I had 22 degrees of freedom. So sure, it was 2 implants side by side. I had plenty of degrees of freedom to be able to provide a tensionless environment for passive fit, John.
So if you have an implant, though, that has a super tight connection, like a 3-degree Morse taper,
Right.
what do you do?
Man, that's
if your
tough.
desire is a splintum? Well, you have to go to the next part of the book. You have to go to a multi-unit or transmucosal type of abutment, a conical abutment, whatever you want to call it. And what these are abutments that we've all seen before on, say, all on 4, all on 6 types of cases, where you have an abutment that allows for you to engage the conical connection.
Old school guys will call these a second stage abutment, right?
Yeah, exactly. Secondary abutment. And so you're placing this abutment into the implant, and then you have a secondary screw, which is going to hold your restoration in place. And of course, when you do this, you now end up with a huge amount of degrees of freedom. You can correct for all kinds of angulation problems, but
these were created for all on 4, full arch situations. And just the other day, John, I was finishing a case, and I said, you know what, if I went back, I'd already started this, and I'd put multi-unit abutments on this case, I think that I would do it differently now, because what he says here, John, is he said there's no evidence to support that adding a secondary abutment will reduce bone loss. But in fact, there's evidence to suggest that you're going to have more prosthetic complications.
More complications because you have 2 screws. You have a screw that is small that you can only torque to 10 to 15 newtons, and you have, or newton centimeters, and you of course have now another part you have to buy, which he doesn't talk about, but it adds cost. So the question is there an advantage? And I think that what we can say is that there is an advantage for these really tight connections, these Morse taper connections. But this gets us, and again, Wes, we don't want to give it all away, but this got us thinking about implants. And does that mean that you need to have 2 types of implants in your practice or more? One that you use for the deep subcrestal placement types of situations, and then one that you use for splinting. And we're just going to leave that out there and just say, we don't have all the answers, but it is an interesting thought, because do you want to be using these secondary abutments with the potential for complications in your very tight, because he's right, there's no advantage to this except if you can't achieve passive fit because your connection is so deep and tight, essentially, with degrees of freedom. So I've used these types of abutments many, many times with implants that have these really tight connections because of necessity. But should we be doing that, Wes? Or should we be choosing an implant for these splinting situations that allows us to go direct to the implant by having more degrees of freedom in the connection? What used to be considered maybe a bad connection, like, say, external hex, for instance, should we be going back to external hex implants for our splinted restorations?
Well, it's probably a knee-jerk reaction in a sense that we probably don't want X hex.
Right. But I want to stir the pot a little bit.
But I think that what you're saying is, right, if we take all of the factors into play of what causes bone loss, and what he's saying here, right, is that we want no movement when our implants are placed close or below the bone, right? That there is a risk. And if you don't have a passive fit restoration, meaning that it fits like it's supposed to fit, tension-free, then you're going to introduce a microgap that could promote bone loss. And that's the crux of this, is that we want a tension-free environment. It's going to be, you're going to have less prosthetic failures, less prosthetic complications, but you're going to have to start thinking about the type of implant you're placing. Now, let me tell you what I know. I've been placing implants for 15 years, and I used to be, guides really were not other than poor man's guides, were not a part of my practice. And I was the guy that was asking for the parallelization pins, right? And just to freehand parallels before we had, guides. And then CTs came, and I jumped on board the CT. We did, I was pioneering that whole thing and pushing the limits and just doing some cool stuff. And so what this led me to do, to say, and John, I told you this, is that I guide 100% of the time when I'm doing more than one implant side by side. Because of this right here. Because you never know when. Like if it's 2 implants in a quadrant and they're not going to be hooked together, if it's like, but down the road they possibly could be, I'm going to do everything I can to make sure those implants are pretty daggone parallel. Now, what if you can't parallel them? Because in the anterior, that's a real problem, right? And we're going to talk about some stuff coming up in this next chapter, I think, that really can boggle your mind, because if you can't parallel your implants, well, that's a problem, especially with these deeper connections. And one would say, jump on what John said and just use a X-hex, and you can parallel just about anything, right? And I don't know that that's the right answer, and I don't think that's what he's saying here, because there's a happy medium of what we're
But maybe
trying
we
to
should
achieve.
be looking at implants that have a little bit more give, a little bit more flexibility.
When we're splinting them.
When we're splinting them. And of course, still following the recommendations in the earlier chapters about realizing that you're having a trade-off, Wes. The trade-off is if you choose an implant that has no Morse taper, and you're doing that because you're going to splint, well, now you're also losing some stability of the connection subcrestal. So if you're splinting with bridges and you want to be able to go direct to the implant, you probably should be thinking about not placing that implant way subcrestal because you don't have a Morse taper. And I think that's what's brought us back to sometimes just having to rely on these transmucosal type of abutments, because we like the idea of having a nice connection that's stable subcrestal.
You know who this upsets? You know who this upsets more than anybody? Is the general dentist that's placing implants that really can only afford one system. Right? Or
makes it harder.
And I'm not saying afford, but it does make it harder because maybe you can't you don't want to stock the extra inventory, right? Because that gets expensive, and you have to train. And in the midst of surgery, I'm just telling you, decisions are being made that could impact the bone around the implant down the road. If this is a patient, this is where we kind of come back to our monologue. If this is a patient that is slowly losing their teeth, right, and we're transitioning from teeth to implants, which happens, right? I mean, we do these cases. Then what type of implant are you placing, right? And if you're doing immediates, like, how do you navigate that, right? In this book, kind of, if you grasp the concepts of this book, it helps you navigate, hey, look, if I'm going to splint or I'm thinking about splinting down the road, I may want to choose this type of implant, this type of restoration.
And I think that leads right into the closing thoughts on this chapter. And we saw Linkevičius present at the AO and the Prosthetics Forum. I think it was last year.
Really good.
And he, everybody's talking about, showing these nice all-on-4, all-on-6 cases. And he gets up and kind of says, hey, just so everybody knows, that's not what I do if I can avoid it. I'm trying to move away, because he is citing research showing the prosthetic complications of these splinted restorations compared to smaller segments. And his preference, as he says here, is he would prefer for restorations not to cross the arch. And he would prefer more implants, smaller segments, more fixed partial dentures versus hybrid type of restorations. And he has some pretty compelling data to back that up. And so I think that what we have to take from this is, yes, we potentially could, but I like the fact he justifies why he thinks this is. He thinks it's because of what's been described in the chapter: lack of passive impressions, inaccuracies of larger bridges, tension caused by splinting non-parallel implants. Those are all things we can run into in the all-on-4, all-on-6 type of restoration. And the more implants we're trying to splint, the more issues that we have. So take that for what you will. It doesn't mean those restorations don't work, but it means that you've got to be on your game in a bigger and bigger way the more implants that you're trying to splint, so that we achieve less prosthetic complications.
Well, John, this has been a great chapter. I think as we move on here into the next chapter, we're talking about, as we've been talking about, tie bases and things like that, but what type of abutment should we be using, right? We're going to be talking a little bit about abutment alternatives in Chapter 15. I think, again, the advent of the custom abutment, right, was a big deal in dentistry. You know, we go from the UCLA. Now, UCLA was basically an abutment that you waxed with full contoured wax and you cast it, right? You put it in the old... the centrifuge, and right, always the nervous time when you're investing your wax and like you're praying that this works, and you know, the inaccuracies of that, John, super inaccurate. I can remember some of my first bar wrapped in acrylics. They were cast gold, and we would try them in and we would segment them. Just go ahead and plan on it, and we would Duralay pattern resin the pieces back together and then send it back, and then have them solder it. And so the thing that's changed is milling, right? Milling machines have allowed us to do some amazing things. And as they've gotten more affordable, we've seen a lot of milling machines come on the market that can do some awesome stuff. So the stock abutment, right, that's been used for years, and I lamented about as an early implant clinician, but especially if I was always cement retained, right? I would just always ask for a custom abutment. Luckily, in 2004, when I started my practice, Atlantis, and there was custom abutments, and we were still doing some UCLA, was just coming up on the market, but I was taught UCLA for single units. And what it allowed you to do was raise those margins, do more of a natural tooth contour to your abutments, plus you increase that abutment surface area, which allowed your crown to stay on easier. It just made things more cleansable for the patient, and it looked more tooth-like. Well, stock abutments, the bad thing about those is the margin. If you're placing subcrestal implants and you're going to try to cement that on, that's like 3 millimeters, maybe deeper, interproximally down below the gum line.
Big problem.
And you know, one thing he brings up here in part of this chapter, he says it's unknown yet on some of these tie bases where you're cementing the restoration outside the mouth, right? There's a cement margin right there. And if they're looking at, does that cause a harboring of bacteria, which could lead to inflammation, where that is so far down on some of these tie bases below the tissue, John? I think custom abutments have changed dentistry, right?
Yeah, absolutely.
Especially,
and he goes into talking about what type of abutment design should we choose if we're trying to achieve proper cement situation and a proper screw retain. And I think, you know, first we should talk about what is necessary if you have to cement.
Let me ask you this, John, before you get into that.
Yeah.
How many of your posterior restorations are you having to cement right now?
I mean, 0.
Yeah. So it's the anterior we're talking about.
Right. Yeah, it's the anterior, because we really shouldn't be having to cement in the posterior unless you have a real big problem with your implant surgeon, you know, or if you're doing your own surgery, you know, we need to work on that, because it shouldn't be.
So in the anterior.
Yeah, in the anterior, what do we do if we need to cement? And if we've exhausted all other options, well, we've got to decide where our margin placement is going to be with these custom abutments. And based upon the earlier chapters, in terms of cement removal, we know that he proved earlier on through some studies that the only way to effectively remove all the cement was with a 0.5 millimeter subgingival margin. That's the furthest down you could go and still be able to reliably remove cement. So he's advocating for that being the deepest margin that you would place on a custom abutment in the anterior.
So you're saying 500 microns?
Yeah.
So how accurate?
How good can our impression be, and how much tissue change do you have? And you know, we don't want to get again into the high weeds, but you should, if you really want to go next level, to learn how to make anterior restorations, you'll find this in every major textbook, every PROS program. You'll all find it at RDI, which we teach it, is making a customized impression coping. Essentially, this means that you're going to use your provisional restoration and you're going to copy that subgingival contour into your impression coping. And there's whole techniques that describe how to do that. So even if you do that, though, Wes, and you have a customized impression coping and you take an accurate impression, it's still difficult to not displace the tissue in some way you don't want when you inject that light body down into the sulcus to try to capture that. And so his solution, which I found ingenious, was to have the lab make a replica abutment that's plastic of some kind and try that in and look at the margin.
And then modify the margin.
Modify the margin intraorally and send it back to the lab for them to redesign the abutment based upon that before making the definitive abutment. I thought that was an ingenious idea.
That's pretty awesome. And you might think, well, watch this make a difference? You know, is this really that important? Well, if you want to have zero bone loss around your implants, right, it's really getting important. And where
you want to take the cement off or not? You know,
so
and that's
pretty
much
John,
what he's saying.
How many periodontal disease patients do you have implants in that you have cement retained restorations?
Too many.
Too many. Right? Because he pretty much says that you really shouldn't be doing cement retained restorations in periodontal disease patients. Now, that doesn't mean active. That means whenever.
Ever.
If they've ever had periodontal disease, that the cement is so much of a risk factor.
Yeah, they're too susceptible.
Because it's so basically what we're saying is you got to use some other fancy stuff.
Right. So you could try this technique in a patient with no perio, or if you want to really, be a hero and you think you can get all the cement off, then this is a great technique. But I think, very quickly after seeing the complexity involved in that, we kind of step back and go, well, let's try to avoid that. Let's try to avoid cementing in the anterior. And his other approach that he uses is having like a telescopic abutment type of idea. You make an abutment where the margin is purposefully elevated above the tissue 2 or 3 millimeters, and then you make a crown which is going to cement to that that's the same shade. Of course, he goes into the fact there's problems with hiding the cement margin. But let's assume for a moment here that we're going to just move away from cement, Wes. So what are our options? And he goes into the one that's recently become more popularized, which is an angulated screw channel access, which means that, and you guys have probably heard about this, but if you haven't, it's having the lab mill in an angulated screw channel into the back of your crown to basically shift the exit point of the screw toward the lingual by somewhere around 15 to 30 degrees, depending on the system, and then using a specialized driver that engages this screw at an angle but can still achieve the torque that's necessary to hold it. And I think this is a good solution, but I think, and he doesn't talk a lot about the negative with this. What I've found with this is that there's a problem with thickness on the lingual, because if you move that screw channel access lingually, you have to still have enough abutment wall thickness in order to achieve strength.
And there's also a problem with some of these deeper conical connections. It's just not possible. You can't.
Yeah, exactly.
It's just that
you can't mill it in there.
You can't mill it in there. And
so it's good if you have the perfect scenario for it. I think it can be great. I've done a handful of these cases to try it out, and so far I haven't had any problems.
Well, why not just use composite to obturate the hole? Like, just do it right through the facial.
That'd be interesting.
Well, I mean, he shows that.
Yeah, it'd be interesting, right?
He shows he shows a train wreck of a patient here that's going to lose their teeth, and essentially
you could do that.
They do a crown and bridge style, and he obturates the hole with composite, and the patient just accepts that.
Yeah, you just accept that,
right? You know what you're going to be doing. You're going to be polishing that every time they come in. So what's the big deal? Right.
You could also do a lingual set screw, which he doesn't talk about.
Yeah, we've done those, and those are interesting. I've got a few of those.
They can
out
work,
there.
but same thing. You can have bulk issues, and you can have small screw that you're dealing with now.
There's no perfect answer, right? It's really we're kind of limited right now. you know?
But he does have a great decision tree, which I like. He says,
good.
if you've got perfect position of the implant three-dimensionally, well, we can do whatever we want. We're going to screw retain it perfectly. If we're not where we want to be, then we have to decide, are we going to go with a purposefully supragingival margin, say in the posterior? That's very doable. Or in the anterior, we're going to go with one of these 0.5 millimeter subgingival margins, which means maybe a replica abutment. Or are we going to go to an angulated screw channel or a lingual set screw or something of that nature? And yeah, there's no perfect answer when your implant is not in the perfect position here.
I think you have to really come to terms right now, if you're listening to this, if you really believe cement's a problem. Because you're going to start thinking about it more after reading this book, right? I mean, even more now, right? Even more now, I think I'm considering other things, right? I mean, and that's okay if you don't believe, but there's just like overwhelming evidence by multiple clinicians. It's not just Tomas, right?
No.
I mean, Chandra Wadhwani.
Right.
I mean...
Yeah, you got plenty of people out there who know this is a problem. Yep. Well, I think, Wes, this is one of those chapters that makes you really think about, really the last two chapters. I mean, these are things that challenge the way we think, and I think they just define kind of the current standard. What should we be doing? What shouldn't we be doing? I think it really challenges us to come back to the basics of understanding three-dimensional implant position. And now that we have our early chapters on placement, surgical placement, we know that if we place an implant ideally with the thought of, like you said earlier, are we going to splint this? Where is the screw going to be exiting? Let's make sure that we don't put ourselves in a situation where we have to make these compromises. And maybe it tends us more toward augmentation, in certain areas. I mean, both soft tissue and hard tissue.
It definitely pushes you into the CT realm and the three-dimensional restorative-driven surgery, right?
Yep.
I mean, it definitely makes you say, hey, do implants? I mean, really makes you think, whoa, back up, let's do a little treatment planning. Let's just not jump right into the production, right?
Yep.
Let's just not drop some titanium today, right? I mean,
I think too, it's hopefully going to get you thinking about, even simple thing as how you're going to take your impressions differently, making sure. Yeah, exactly. And one other thing while we're on the subject of this, Wes, I just want to cover, because we haven't really talked a lot about it, is scanning, implant impressions and scanning.
Hey, it's not even in here.
It's not even in there.
It's not even in Zero Bone Loss Concepts.
That's interesting.
And I know Tomas uses scanners.
Right.
But it's not.
Right.
It's not in this book, John.
It's not in there. So
I wonder what your buddy, Mark Ludlow, Dr. Mark Ludlow, would have to say.
Who's speaking at the AO, by the way?
Who's speaking at the AO, would have to say about a full arch scanning protocol that's validated without using cement as a slop gap measure.
Yeah.
I love it. I don't call it cement gap anymore because I call it slop gap.
It's the slop factor.
It's the slop gap, guys. So I wonder why it's not in here.
Yeah.
Because
I want to go back to years ago when Encode came out.
I just had a phone call from a dear friend.
Yeah.
That he said that it's imploding.
Yeah. And it doesn't mean that it's not a good idea.
No, it's
because
a
great idea, and it really helped pave the way towards scan bodies being more understood and accepted, and good on Biomet 3i and 3M early kind of worked with them to try to develop a scanning digital pathway to make these restorations, even though it was super convoluted. They did it, but for multiple units, Carl Drago, who was Biomet 3i's, lab, he wrote the book for them on lab stuff. Well, he published a paper with Ed McGlumphy at Ohio State saying it wasn't good enough, that scanning using Encode wasn't good enough for bridges, and he recommended doing a framework try-in
and sectioning
on every single
so
one.
When we met Brad, the dental lab guy, we were talking because we live in 3-eye country, right?
Yep.
And we were asking him, like, because we had troubles with it, you and I.
Yeah.
And we asked Brad, the dental lab guy, and his brother about what they thought about Encode, and they just laughed because they said we couldn't make it work. Right?
Well, I remember the discussion with Drago, and he was saying that when he tried to figure out, they were using glue to glue the analogs in, and it was like this called RoboCast, so-called method, and they were trying to figure out where the inaccuracy was, and they were going down there, and they couldn't even figure out. They wouldn't even tell them what the glue was. So like the glue obviously has a polymerization shrink. Anyway, so the point of this, and here we are about to release this for the AO. You know, Zimmer Biomet's going to, you know, be all over us. Hopefully, maybe they have some new data. So that's the challenge.
The title of the whole meeting is Evolving Technologies in Implant Dentistry.
So maybe they've made this better. We would love to see a
listen,
workflow.
Come get us because we are going to do some man on the street stuff.
Yeah, if you got a new validated workflow or some data that we haven't seen since this time, show us. And that's why we're talking about
Dent Supply. Sorona has something.
Yeah, that's why we're talking about Mark, because Mark, I think, has been talking with them to try to figure out a way to validate a workflow that we could do
Some
digital
of you out there say there
framework.
is validated workflows, right? There's these people out there. You know who they are. You know, they're out there that are saying, hey, I got a workflow that works. But everybody is using cement to make up some of that.
You know it.
Right.
So they're going, oh, yeah, my system works. Well, of course, they're using 4 different softwares, 3 different scanners, you know, and they're like, they're pulling rabbits out of hats. But in the end, it all comes down to the same thing every single time. It's they're doing a verification jig. A lot of them are still doing a verification jig, and they're using cement in the end to take up the slop. So,
John, it's been a great episode, man. Another zero bone loss concepts in the book. We've probably got another one coming your way right after this to finish up the book. Dental Guys Book Club, in effect. Looking forward to the Academy meeting, right?
Yep.
And we'll be seeing you there. We're going to be busy, but we also want you to come high-five us, say hi, right? Because we definitely want to know that you know who we are, because that keeps us going, honestly.
Yeah,
like, really,
us.
You guys have been sending us some encouraging comments. If you haven't sent us something, right?
Yep.
Don't think that we don't read it. Like, I was just reading a rep from the West Coast from a well-known implant company sent us an amazing email. And I know he's listening to this.
Yep.
And I really appreciate
you,
that. We really appreciate you. We look forward to seeing you if you're going to be at the AO. So any of you guys, please come and say hi. We'll be there. We'll be speaking at the Young Clinicians Luncheon, and we're super excited about that. That's Friday at 11:30, 11:45-ish?
Yeah, it's around lunchtime.
Yeah, around
12-ish.
lunchtime. So this has been good. If you listen, how people find out about us is if you share, right? Like and subscribe. We're on YouTube. We're on Facebook. We're on Twitter. We're on Instagram. Follow us there. Look for the Dental Guys. Give us a good review. We need you to go on iTunes right now and give us a 5-star review and tell us why you like the Dental Guys and maybe why it's changed your practice. Something we might have said, I don't know, right? Because this show's changed my practice, right? Because when you study books and you read and you dive in, it's all about taking it to the next level. John, I'm excited about tomorrow and us traveling together. It's going to be a great time. And so for John, I'm Wes, and we are the Dental Guys.